Thank you everyone for joining. I'd like to start tonight by acknowledging the Aboriginal and Torres Strait Islander peoples as Australia's First Nation peoples and the traditional custodians of this land. We respect their continued cultural and spiritual connection to country, waters, kin, and community, and also pay our respect to their elders, past, present, and emerging as the custodians of knowledge and law.
Oh,
So
good.
I'd just like to thank everyone for joining tonight. For those that don't know me, my name is Kayla Vella and I work for the PHN based in Mackay. We've also got Carly on the line tonight. I don't know if she's there, but Carly's also based in the Mackay office in our workforce development team. Just to let you all know, this webinar is being delivered in collaboration with the Essential Skills Workshops that will take place in Mackay, Townsville, and Cairns throughout August and September. So if you're interested in attending those, I'll pop some links in the chat while the presentation is happening, and you can learn more about those through the links. So I think that's it, Kim. I'll hand over to you to get us started.
Well, welcome everybody. We love a Thursday night, our session together. I'm sitting here in Gadigal country, and I don't know if you can tell, but I'm in mohair and I have a blanket across my knees because we have got a blast happening across the East Coast. So hopefully you're all up there nice and warm. I can see a couple of short sleeves up there. I was just saying to Kayla that my daughter's just been up in Warwick in Townsville for, that area as well working, and she said it's been -5 and -4. So I think we've had a cold blast across the nation. So I'd like to first acknowledge
around the Townsville area, -4, -5.
Oh, there you go. All right, so we're going to kick off tonight just with acknowledgement to the traditional custodians on the virtual lands on which we all meet. As I said, I'm on Gadigal country, so I'd like to respectfully acknowledge the elders past, present, and emerging, and also to the people who might be listening now and maybe to the future recording. Now, could I just request that everyone just puts their microphones on mute, just so the recording is not going to have a lot of your chatter. I'm just going to mute a couple of people. Also, do you mind keeping an eye on that too, Kayla? If there is a question, there is a chat function. Kayla's going to keep her eye on that for you all, just so that if there is a question at the time, I'm happy to take a question right at that point, okay? So she's going to turn on her camera and then pose that question to me. So hopefully you enjoy tonight's session. Hopefully I can bring the energy and the love via this Zoom link for you. I have had a couple of questions before we started tonight's session, and I will respond to those as we go through. So let's kick off. So why do we triage? And we know that we want to make sure that we are prioritising who needs to be seen and when, so that we're providing the right timeliness in terms of care, and that we're making sure that we can adjust our schedule throughout the day, even if we do have, appointment schedule really chock-a-block. Can we make sure that if there is an urgent case or a client that's come in that we do need to address straight away, that we are able to then prioritise our day? So that's the ultimate aim.
Yeah,
and
I'll do it in a minute.
So, Kayla, do you mind just popping that on with a little bit of a mute there? All right, so we are looking at making sure that we are absolutely prioritising people, making sure that people are getting the attention that they need, and not just knee-jerk reaction calling the ambulance or just dropping into accident emergency centre, which can happen, of course, when people particularly decide that, maybe the primary care setting has got, no bulk billing anymore, and they think that, well, I'll just go to the accident emergency, which is often the case, particularly in the Healthy North Coast catchment where I do a lot of work. 18 to 24-year-olds are using accident emergency as just their usual doctor. So again, just making sure that we're getting people in timely care and having that clinical governance from a team that they consistently see is the way that we're going to make sure that people are addressing and noticing when something's not quite right. So what is the definition of triage? Hopefully you've all seen this. You probably all know it. And hopefully it's just a refresher for your accreditation purposes, right? So if it is, that's okay. That's okay as well. It's just a good chance to go over what is it that we're trying to do. So we're looking at that systematic process. It usually happens very quickly, and it's responding to a person's level of urgency at that point of care. Now, they could turn up, right? They could turn up, and we've had certainly many a time when someone's turned up in a wetsuit and said that they've got a severe cut under that wetsuit, right? So how do we know whether or not it is severe or not, unless there's blood dripping through, the bottom of the wetsuit? Or if you've got someone on the phone, you might be taking their symptoms that they're describing at face value, right? What is it that person is describing to you at that point in time? And again, we need to stay really objective and just listen to the clinical criteria of what the symptoms are. And when I say objective, what kind of things do you think I mean when I'm saying objective? Do you just type it into the chat box and let's see what you come up with? When I say objective, what do I mean by that? Let's see, Kayla, is anyone coming through with anything there?
Not yet. No messages yet.
Have a go. You've even potentially got Google there. Objective. What does it mean when I'm saying you got to stay objective to it? Let's see.
Got one in.
The facts, right? Neutral to it. So we're not determining whether we agree or we disagree at this point in time. We're staying to the facts. Now, as I said, you might have somebody there. Respect to objective, what we mean is that we want people to absolutely make sure that they are taking in the facts, right? Versus going through that process of do I agree, do I believe, do I trust, etc. So we're absolutely going through that process of listening to what that person is describing in terms of their symptoms. Now, this is some little fun facts for you all to consider. The clinical team's component of it is to successfully implement a safe triage process. The clinical team must support the reception staff, okay? So for reception staff particularly, know that the clinical team need to determine red flags, and they know what red flags are, what they're concerned about, and we want to make sure that they guide the non-clinical staff decision-making about urgency and the timeliness of care and who needs to see that person. Also, they'll update non-clinical staff on any health alerts, i.e., let's not talk about the pandemic, but for things like that were changing so rapidly, we absolutely had to make sure that there was someone who was clinical updating non-clinical staff on what might need to happen, and provide and facilitate further triage training. So if you do have a clinician on your team and you want to address somebody who maybe doesn't get to tonight's session but might actually start with you in a couple of weeks' time, that you onboard them in the triage process. Now, this is being recorded, so you can utilize this recording to do that training with maybe a new staff member, or someone might be on holidays or might be sick tonight and not be able to get there. And we want to develop policies, procedures, and have decision making about who's doing what components of it and who's responsible for things like calling 000. So we're going to be sharing and helping with any clinical decision making across the course of time. So what is it that we're trying and aiming to do? Reception staff, they're communicating effectively. Now, I'm going to come back to this key component here about communicating effectively. And I'm just going to pose a question to you that I want you to respond to in the chat bar. Have you heard of ISBAR? There's just a yes or no response at this point in time. And I'm going to come back to it. Now, if I haven't come back to this, I want you to remind me, because it's really crucial that you guys know and identify this particular acronym that I was just out teaching and training across Australia just recently. It's a fantastic acronym on how do you clinically hand over to somebody in a really efficient and effective way. Again, reception staff need to determine the level of urgency and identify red flags. This person might be talking about self-harm. They might be talking about that they've got chest pain. They might be talking about that they can't feel one side of their body, etc. And that is the immediate attention. Now, hopefully, Kayla has popped in and what we call a POPGUNS triage tool into the chat function. If not, we'll pop it in again for you. And I want you to download that, grab it and put it on your desktop, because it's going to be assistive in what we're talking about tonight. So open up the chat and download that resource. The comms team have done a beautiful job putting it together. It's really nice, and it's going to be a nice way of you identifying the person that's calling, and also reception staff capturing the critical details of what is required legally, medico-legally, if you do receive a phone call and potentially they're not your patient, right? So you got a bit of paper that you can write down those 3 identifiers and then start circling what those symptoms are that are being described. So there's a beautiful resource called the POPGUNS Triage tool in the chat function that I want you to grab out. And we, again, want to make sure that everyone is inducted to the policies and procedures and have access to things like the POPGUNS resource that I've just been talking about at their reception desk. Now, commonly what happens is people actually laminate it, but I'm saying paper copy, so you can write on it, draw it, and then scan it into that patient's file if they're an existing client. If they're not an existing client, then you've got a record of who rang, okay? You got a copy of that stuff. And you've also got a point in time copy so that you can refer back to it. There's nothing worse than someone saying, can you remember last Thursday somebody rang at 3 o'clock in the afternoon? Can you remember what you've done? Our brains are really poor historians, okay? So having a piece of paper that you've actually gone and written all over and the patient's 3 identifiers is going to be very assistive there as well. So what's the reality? I've just described, what's the gold standard. The reality is we are all doing the best that we can with the current resources we have. No doubt, like the rest of Australia, people are sick in your workplace, you're short-staffed, you might have competing demands. We've got changes happening in general practice at a really big rate at the moment. We've just had the aged care incentive come through in August. In November, we're going to have changes to care planning. So constantly these things that we have to wrap our head around, right? And then we have to go, oh, actually, my doctors are away, some are sick, and I'm really short-staffed already. And, now I've got to put someone and fit them in. Who am I going to fit them in with? And as a nurse, I've had that same experience where I feel like I've just been ping-ponged from one doctor to the other, to the other, to the other. And everyone's saying, I can't fit anyone in. I can't squeeze anyone in. And it's really hard, isn't it, that we're under strain, we're under stress, we're under time pressures, but we need to have a consistent way of dealing with triage patients. The big super clinic that I ended up going and working in after I was working for 14 GPs and just one general practice nurse, which was me, down in the surf coast of Torquay, down in Victoria, I ended up working in a big super clinic, right, as a coach, a nurse coach. And they had a great approach to their triage. They rostered a GP on to take whoever it was the overflow. So they would see their regular, but I would know as a practice nurse working in my treatment room that Dr. X was today's on-call doctor. So I knew not to ring around to every single other doctor, just to go straight to Dr. X. So pretty cool when you've got some structured processes like that in place. So again, How does triage work in your practice? I want you to really think about that and discuss this as a team. What guides decision making in relation to scheduling of appointments? Is it that your on the day appointments are being already taken before you get to on the day? Because people are going, well, I need to squeeze you and I need to see you tomorrow, so I'm just going to take those on the day appointments. Do you have an agreed policy or procedure that you follow? Or is it just clinician discretion that people do what they want whenever they want, right? And I've worked in both ways in my two different clinics that I've experienced. And also I teach and train across Australia in lots and lots of different general practice settings. So it can be a mixed bag, right? But I want you to ponder what's guiding this and what can we remediate at any given time. So I'm just going to pause and have a little look in the chat function and see what you guys have been saying in there, just as I've got lots and lots of messages in there. So let me just come back in. Yeah, great. So when we're talking about objective, I've got neutral, not jumping to conclusions. Now, I don't know how many times that we see a name or think of a person, we go, oh yeah, I know what's going to happen here. Listening to the facts. Yes, if you're going to stand in front of a courtroom and they say, what led you to make these decisions? We don't want to hear that you thought X, Y, and Z about it. What was that person describing to you? Was their symptoms? Are the facts, okay? Non-judgmental, absolutely. We'd love to all be non-judgmental. That's another whole workshop in itself. Not letting personal bias be a factor in the triage process, absolutely. And that can happen, can't it? We might have frequent flyers who come into our general practice. They've commonly got something going on that we all go, oh, yes, it's the same thing. I had that happen to me in one of the practices. I was working in a smaller practice, and someone with a frequent flyer would come in with a lot of anxiety and ended up having a heart attack, right? And had lots and lots of issues and not a successful outcome. Okay, so we cannot just rule things out as what usual things that they might come into your clinic about. Okay, so here we go to ISBA. How many of you knew about it? No, a couple of yeses, a lot of no's. This is exciting for me because ISBA's cool. So hopefully if I can teach it to you, you really feel quite confident. There's sort of about a half and half there. I can see Kayla's given you the resource and she said she'll send the resource via email, but I need you to use it for tonight. So if you can just scroll through and grab that, that would be great. Okay, so if the doctors have a preference, great. So they follow POPGUNS, but there's also some clinical decision making there as well. Absolutely. Yeah, and the reality, right, of working in accident emergency. If we only
yeah, just about 3 people.
can someone just mute themselves there? We only have one doctor, so half the urgent calls get sent to the ED. I'll just see if I can find who is.
Yeah, that's all good. I was at a large or regular for that box. Large.
Let me
Yeah,
just
and what was the drink of that
see
one?
there.
Pepsi. Pepsi, that's all good. The coffee.
There's one Kim under. Oh, it's gone.
There I go.
Thanks.
I've got it. There's a big show going on here with lots of things going up. Okay, so what happens? How do we make sure that we try and remediate what we can? Yes, the realities are sometimes we're understaffed. So if there's only one doctor, maybe it is that they go to accident emergency to get triaged. Okay, there's no judgment here. That's kind of all that can happen. So, oh, someone's even given me the ISBA acronym. I love that. And Kayla's just given a plug there about the essential skills training. All right, so let's move on. What are the components of it? First and foremost, you need to be orientated and inducted in it and trained in it. There's no doubt about it. You don't just know about POPGUNS. Now, I know a lot of people say to me, POPGUNS, never heard of it. Then when they see the resource, they go, oh, that thing, I've seen that at the reception desk, all right? So POPGUNS is its acronym. And there needs to be clinical processes and policies in place. Hopefully, you're signing off on policies and procedures where each new year, maybe when you're inducted. And what I particularly really celebrated at the big clinic that I went and worked for, every 3 months they'd do a mock scenario. And it was really interesting to see who panics, who actually knows where equipment is, right? Who actually mans up and says, oh, yes, actually, I'll be the documenter, I'll be X, Y, and Z. But our clinical team will put together a scenario and invite someone in who might be a family member or a friend of somebody, and they would run a pretend, right, mock scenario so that we could see whether all our policies and processes were effective, and then what bits were missed, and then we could clean it up with that quality improvement or approach. Okay, so I want you to consider the following thing. A mum rings at 10 a.m. Monday morning. Don't we love Monday mornings? And says, my child is unwell and I'd like to see the doctor today, please. I want you to consider and type in the chat box, what would happen in your clinic? Would you have an appointment available? What questions might you ask? And what could be a barrier here? So I'm just going to give you a moment just to see what kind of things come out. Let's see. What could you ask? Would you have an appointment? What questions? Great. What are your symptoms? Describe what they mean. Yes, absolutely. That's important, isn't it? Unwell is very broad. Getting a little bit of a history. How long for? Has it been 1 minute, an hour, 2 days, a month? What symptoms are presenting? The age? Because again, we don't know that from here, do we? Is it a person that or a patient that we normally see? The duration? Yes, definitely the symptoms. How old? What symptoms? How long are they current patient? How old is the child? How long have they been unwell? And ask what is happening. Need more information? Absolutely. Length of time, name, age, how long? Yep. What doctor do you normally see at this practice? What a great question, right? Probably no appointments. That's common, isn't it? Ask age, symptoms, history. Is anyone in the family also experiencing symptoms, any pain? And if appointments available, offer first appointment, and probably have an emergency appointment. Barrier is solo GP. And if that person's infectious, what do you do? All right. So absolutely, there's a few things to consider with all of this, isn't it? So why is it difficult? Because our appointment system and scheduling is very complex. As we just made note of, there could be people off sick. There could be people that have already got, maybe a 2-week wait or a 3-week wait to see their usual GP. Time is scarce and it requires that rapid decision making. There's long wait times, usually for routine appointments. And we're making a rapid decision, a clinical judgment at the coalface, and taking that person's word for it, aren't we? So we're not actually necessarily taking. Just one moment. I'm just going to mute whoever. So what we're trying to do is take that client's word for it and make a decision based on that. And, there could be possibility of adverse clinical events. Patients' expectations are potentially, oh, yes, well, you'll definitely see me. I'm used to calling at 8:30 in the morning. I don't know how many times our reception staff used to say that. Call at 8:30 in the morning and we'll get an appointment. And of course, there's only so many appointments and so many people that can be seen on the day. And if I will try and book my patient in ahead, they'd go, oh, don't worry about it. I'll get an appointment if I ring at 8:30 in the morning. I'm like, it's not the point. All right. So, and again, if we have someone off sick in terms of our staff, and we might have unsupported decisions, i.e. what I was saying before, I could make a clinical judgment. This person needs to be seen by a doctor, and all the doctors go, no, can you try somebody else? Try somebody else, try somebody else. So it can be challenging. And good response there. Lee just may mention if there's no appointments, go to the urgent care centres, right? Like that's been a great thing that's come in now. So why are we here and why are we doing what we're doing? It's absolutely part of the accreditation standards. As you can see here, part of it is that we need to have different consultation types to accommodate patients' needs. We saw through the pandemic that we were very responsive. All of a sudden now we can do telehealth. And I have to have a little chuckle because I did have a remote consultation the other day. I usually live in Biripi country, which is Port Macquarie, and I was down in Gadigal country where I am right now. And I had a doctor's consult and she ended up ringing me. She said, "Oh, I'm so sorry, Kim." She said, "I've forgotten how to do telehealth." She said, "Oh, so I've opted for the phone." I said, "Look, that's absolutely fine." I said, "But get practicing again, right? Because there will be infectious patients that will need it. And we need to make sure we've got a triage system and we have a recorded message there. There's no doubt about it that we need that 000. So all members of the team must know how to identify people with an urgent medical need and what are medical emergencies and know how to reprioritise appointments accordingly. Now, you guys are amazing at doing this. You know, us as clinicians will be sitting there going, "Oh, yes, my day just went a bit sideways because now I've got something urgent happening." But all of a sudden, the reception team are onto it and have rescheduled everybody to free up our day, not to overwhelm everyone as best as they can. And of course, seek medical assistance from an appropriate clinical team member. Who is that and how do we go about it? Doing telephone triage, as I said, again, admin staff need to know that they must ask if the urgent is, if it's urgent to maybe check in first, if they can put someone on hold or redirect them to 000, either one. So have a triage system in place and retain evidence of this. So policies and procedures and the guidelines in the reception areas, which is why you commonly see the POPGUNS resource at the reception area, and display a sign in the waiting area for people high risk might deteriorate in their symptoms to tell reception staff. Make sure that they're visible to reception staff as well. You know, commonly if you're immunising, say, and you know that someone has an event sometimes after obviously having their immunisation, making sure that they can be eyeballed and not, you know, out of sight, out of mind. Again, making sure that we have admin staff update the patient waiting list. If there is an emergency, making sure that that person's name is on there. And again, explain to the people in the waiting bay that, you know, there may be an increased waiting time. Also, there's a complete training that is required, and that's again why you're here tonight, that there's a vital role in the provision that your practice supports education, particularly of non-clinical staff, that allows for continuous improvement and mitigates risk as much as we can. So first and foremost, I want to say that most things that come through our door are minor and self-limiting, but some can be more serious and escalate really quickly. So how will you know? So again, go back to that check function. How are you going to know that something's more urgent? What constitutes an emergency and what are you going to do? I'm just going to go back up to my chat and see what you guys are writing. I can see some people are saying we don't have an urgent care centre nearby. Yeah, absolutely. Sometimes it's not an alternative. Bigger clinic nearby. Lots of drop-ins. Some have a walk-in clinic, which is great. And I've got here chest pain, cardiac, immunocompromised, chest pain, absolutely. Breathing difficulties, great. Chest pains, obvious bleeding, yes. Yep, post-procedure, potential infection, yep. And severe pain, vomiting blood, great. Lethargic, yep. Yep, particularly if it's a baby. I don't think you're calling me baby. It's lethargic as a baby, high temps, and sepsis. All right, great. We've got some good things, and we want to just make sure that we're covering off some basic components. First and foremost, is this an urgent matter, or can you give me an indication of what the problem is? Then you've got the 3 identifiers: name, address, and age. Okay. So if you've got the POPGUNS resource and they're not a normal client of yours, you can write those things down. You want to know if they've got a telephone number, if you can't see it visibly on your reception end, jotting that down and checking if they've got anybody with them. Why do you think I say that? Why do I want to check if anyone's with them? Just use your chat function again and let's see. Yeah, in case something happens, because if they become unconscious, absolutely, that's the one, right? If they become unconscious, they're not going to be able to answer the phone, particularly if they're at home still. So checking if there's someone else there and what's their phone number. And again, not forgetting that if I've got somebody on the phone and I say, hey, ring 000, and now they're on the call to 000 and I'm trying to contact them, I can't get through. So if someone else is with them, we've got another phone number. It's nice to know that pretty much as a comfort that you've actually got someone else you can call. Again, what's the nature of the symptoms? Get them to describe what they're experiencing. And then you can see duration, severity, and have they had a previous history of this. Okay, really important. On that POPGUNS resource, you'll see these questions up the top for you. And we're going to act and advise according to the practice. That's meant to say protocol. Okay. And yeah, someone said not only their phone number, check address and see if they're home. Absolutely. They can see name, address, and age there. All right. So there's 3 levels of a medical emergency. We have if they need to be resuscitated, if they need to go to the ambulance, if they need immediate treatment, and if we need to refer them directly to the hospital. Urgent, they need to be seen today, and the clinical team need to triage. And routine is next available. It wasn't just because I was home from work today and it suits me to come down to the clinic versus tomorrow. Okay. Let's now move on to pandemic triage. No doubt we're all good at this, so I'm going to flick through this really quite quickly. Checking the symptoms, making sure, we used to be exposure sites. Now it's everywhere across Australia, isn't it? Temperature check, wait in the car, or we're going to book you in for a telehealth consultation, separate spaces, front desk barriers and screens. And we're down for a few of you, probably temporarily. And I know that a lot of them put them back up again. And obviously PPE for staff. So what are we trying to do? We're trying to make sure that we've got some consistent messaging to our people, telling them, and I know that this has been really tough. I've heard from a lot of practices that even though they ask and check whether people are symptomatic, people are just lying and saying, no, I'm fine. And then they come in and disclose, yeah, absolutely, they got COVID. So it's hard, isn't it, to get that truth telling happening there. But can we put as much signage as we can, just reinforce the messages that COVID's not going away and we don't need to share the love, and obviously have good cleaning protocols and the like still. So what is this POPGUNS and what's it all about? We love an acronym when we are working, particularly in healthcare, and it's a prioritisation of patients and it's a guide of urgency for non-clinical staff. Okay, so that's what that means. And there's a checklist, and these are the directives. So if you think about yourself as a care navigator, where am I navigating this person to based on the symptoms they're telling me and describing? Am I calling 000? Now, I think last time when I was up on Mackay, Cairns and Townsville, there was discussion, and I'm not sure if Kayla, if you've heard an outcome from this as a result of that, that a lot of the reception staff was saying that 000 wouldn't speak to them. They actually only would respect to clinical staff. I'm not sure. Is that the case still? Yep, it's true. It's correct. Yeah, interesting. Recently, yes. So great. Still cannot ring. Now, I posed this question after I came from your visits, and I said to New South Wales, is this the case? And they said, not here. We can call. And same with Victoria. So it's interesting that some states are different. And you think about the Poisons Act, it's all different for each state as well. It'd be great if we could have some sort of national response to that as well. So for reception staff, you can't call 000. You need, obviously, your clinicians to be calling 000. That's going to be the quickest way around that conundrum. Go to emergencies, interrupt the GP, get the GP involved for some triaging, and obviously the nurse to assist. You're probably going to need both team players there. Advise GP as best as you can to see if they can come out and help you, but definitely get your nurse involved ASAP. If they're on the phone, they might be attend the clinic and just booking them straight into the nurse for that to, face-to-face triage to occur. Again, if someone is going to attend today, it's always good to give the heads up to your team that somebody's going to come in. There's been a couple of times when I've come back from a lunch break and someone's randomly sitting in my treatment room and I haven't understood why or what they're there for. So just making sure that we do have good handover processes. So I'm just going to pause and see, only clinical staff can call here in Cairns. We have to transfer to clinical if we're reading 000. Yeah, good question, Carly. If a patient walks in after hours and clinical staff have left, what do we do then? I would ring 000 and tell them that there's no clinical staff left and you're the only one that's there and they need to assist you. Okay. And yes, it's a good point, Kay. You shouldn't have your doors open if clinical staff have left, but it does occur and we need to make sure. And someone else has just said, lock your door once your clinical staff have left. But, sometimes it is the case. So I would be calling 000 and informing them that that's the situation I find myself in. And hopefully that doesn't happen too often for you. The context is everything. So we might get duration. We might get severity descriptions. The nature of it can change as well. And their past history can change what category we might put them in. So just being mindful of that. So a cut or laceration, remember where I said before, if someone describes their symptoms, but they're in a wetsuit, how do I know whether they're a cut or a laceration, in which category? Okay. Post-op problems could also be a certain, range of categories as well. And adult vomiting. If in doubt, always elevate. Okay. I would rather a clinician go, well, I've reviewed them and they're not as bad as what you probably thought they were. No harm done. But if it was the other way, I think that I'd be a little bit more concerned about that. So elevate if you're unsure and get your clinicians involved to help you do that triage process. It is certainly difficult. There's certain components of it that make it really hard to kind of prioritize our patients. We do have logistics, as we just highlighted. Sometimes clinicians might go home. There might be someone that's unwell. There might be an emergency in their house. There might be still patients that can wander in outdoors, or they're in seeing somebody else, whether you've got radiographers or you might have allied, etc. There could be emotional or therapeutic where someone might be going through a grief process. They might be feeling like their mental health is not okay today. That certainly can happen. And obviously the pandemic can change things as well. But there's also medical requests. So it comes multi-pronged, doesn't it? All these layers to what we're trying to do. And satisfying patient demands can be really hard. I don't know about you guys, but not everyone's happy with the decisions that we make. And, as a treatment room nurse, We're trying to prioritise who needs to be seen today, who maybe could be sent to the urgent care centre or needs to absolutely go to accident emergency. The chap that I described with you before, who was someone who was very anxious and would come in and see the doctor frequently. He was describing symptoms that were anxiety related, but he was having a heart attack. And when we said to him, why didn't you go, after we questioned him a bit more, and he said, I've been experiencing this like for 2 or 3 days and it's like this. And we're like, actually, I think you're having a heart attack. And he said, I don't want to go to the accident emergency department. I like coming here. Well, we don't have the equipment, do we? So that makes it really hard as well to make sure that we're satisfying what our patients' needs are and what they're used to, in terms of no one wants to go to accident emergency. It's no fun for anyone. Yeah, it's hard. Even Helene just made a point, exactly what I was describing, right? Some patients refuse to go to hospital. What can we do? So medically, we can triage them, we can document, we can advise them. Can we force someone? We can probably put them in 000 and put them in an ambulance. Certainly sent ambulances around to people's homes before, and we can only do our best there, right? What are the red flags? Hopefully you can see there's doctors ABCD. Danger. What could be dangerous? Certainly a person who we had who was drug seeking, using verbal threats and physical threats to us is dangerous. And my old boys who are all sitting there ready for their INR to be done in the morning, were all shaping up ready to come and save me, and my student nurse, and I'm like giving them the eyeballs of sit down, boys, it's all fine. We've got a door behind us that we can get out and remove ourselves from that situation. What about their responsiveness? Are they drowsy? Do they have speech problems? Are they slurring? Do they have changes in their limb and their face? And make sure when we communicate with people, 7% of how we communicate is with our words. 38% is how we say something, the pitch, the tone. You know how when you think, I don't think I like how she spoke to me just then. And the body language, right, is 55%. So make sure you're looking at your people, right? Sometimes it's how we might be looking down here at our desk, etc. But make sure you scan and see what's going on. Send for clinical staff. When I first started in the practice that I worked in, they thought I was being very dramatic when I said that I needed a buzzer in my treatment room. So I had a massive treatment room, but all the doctors had their own little offices. And I said, if I'm having something happening in the treatment room, I need to be able to alert you, right? No, you don't need that here, Kim. You came out of intensive care. No, you don't need that here. And of course, after we had a few events, funnily enough, we ended up with an alert bell. So again, getting people around you quickly, and particularly clinicians, is useful. Is someone choking or swallowing or having difficulty breathing? Could be bites, right? Something could have bitten them. Again, chest pain, tightness, difficult to breathe. Circulation. Are they bleeding or got a severe headache? And defibrillation. Do you know where it's kept and how to use it? So making sure that you get those annual things done, particularly for your staff, so everyone knows how to use those pieces of equipment. I mean, the defibrillators are amazing, aren't they? They pretty much talk you through it. And the fact that they're out in community areas now is an absolute bonus. All right. We want to make sure that we're observing our environment. How is this person presented? Can you see the waiting room, particularly if you've sat them down from where you are? Like, think about your reception desk area particularly. Or if you're a clinician, can you see that person, or if someone sat them in your waiting bay and you can't see them? I'd rather a reception staff interrupt me and tell me that they've sat someone down so I can go and see them and make sure I eyeball them myself as a nurse. Is this a known patient? And are they themselves, right? We commonly know, particularly if we're in a small town, we know how they normally are. Are they acting like themselves, or are they just being a little bit different from usual? Again, is this a worried parent or a stressed carer? Does this person have a mental illness? Are they feeling exacerbated today? Is it more heightened? Is it more acute? Are they distressed, anxious, or agitated? And do you expect long wait times? And how do you communicate this? Right. So again, just making sure that they are a priority, when they're going to be seen, and sort of give them the indication of that timeline, but you're there, right? So there's categories in, hopefully you can see now, you've probably downloaded that resource, I hope, in the POPGUNS. You've got category 1. Patients need to be seen immediately or seen by the doctor on call. Then you've got category 2, directed to the nearest accident emergency department. Category 3, they're worsening, but they can be referred to the practice nurse. Category 4, again, practice nurse and GP, make an appointment. Category 5. And category 6 is come and see us in 24 hours or call us again if there's any changes in your symptoms. But what I hope you notice is it never really lands on anyone else but your clinicians. So your clinicians are your go-to. The category 1, chest pain, breathing difficulties, you wrote about this before, particularly asthma. It could be thunderstorm asthma. It could be some new symptoms for somebody. They might have had a collapse or an altered conscious state, unwitnessed fall maybe. They might have facial or limb weakness, extensive burns. Again, extensive burns can change very rapidly, so we'd rather them go off and be treated by a hospital versus us. We do not have the equipment. And sick patient concerns. This person's really worried, they're very anxious, and they're not feeling like they're being able to be managed appropriately here. You can send them off to accident emergency there. Again, we want to acknowledge that heart symptoms can arise anywhere. There could be pain or heaviness in their chest, neck, jaw, arms, and back. Particularly women have them a little bit differently than men. Shortness of breath, they might be really dizzy. There could be some nausea and vomiting. And it could, which is what I was talking about before, like the patient I had, present as anxiety-like symptoms. So if this person's got an anxiety diagnosis, sometimes it can be inappropriately mismanaged to be like their usual anxiety. So what do? We want to call 000. We want to get our doctors and nurses involved. We want to go through doctors ABCD, follow all the instructions given to us by the clinician, appoint somebody in your non-clinical team to do the documenting, what's happening, what time. If you're unsure what the words are, that the drugs are, making sure that the clinical team are keeping the files so that you can go and, write those down later on. Delegate tasks, stay calm. You are going to be incredible if you're a non-clinical person, going and running and getting equipment, notifying, getting other team members, keeping, maybe family members calm, the rest of the waiting bay calm, reorganizing appointment schedules. There's so much to be done when there's this situation arising, but very critically, document, and then document some more. Okay, because as I said before, we're poor historians. What about with strokes? We want to act fast. So the acronym, as I said, we love an acronym, is have they got a facial paralysis, like a droop? Is there changes in their arm, particularly as in they've got weakness in one versus the other, their grip strength? Speech, are they slurring? And time is of the essence. We need to get them off quick, smart. Category 2, we need immediate care. So they need to go to accident emergency. So we need to interrupt our clinical team and they need to come and help us straight away. Is there any fitting or heart palpitations, heavy bleeding, spinal or trauma, snake bites, ruptured membranes? Goodness me, get them to the hospital. No one wants to be having a baby in their clinic, let me assure you. And neck stiffness and altered consciousness. Category 3 is if someone's unable to urinate. So again, this is where the context and the duration is really important, isn't it? How long has this been for? And again, the age of the person, because this could be huge if someone's older or very young. Unwell infant, poison overdose, eye injury, severe pain or fracture. Now we've got coming to the clinic now, particularly we want the GP or the nurse to triage, and it comes down into timeliness again here. So we've got a person who's unwell with a fever and it's been longer than 24 hours, particularly if they're an infant or they're elderly, we want them to come in now so we can review them. Pregnancy, pain and bleeding, if there's any changes in their visual field, if they've had an abuse or assault, and no doubt you'll be calling the police as well to come in. So again, utilising your team, your admin team, to get that person to come in, particularly as a police officer, so that you can actually get some further assistance. Patient carer, high concern. They know this person, whether or not they're being hysterical and over the top. We need to take what's been described. Remember those objective facts? We need to take them into account. Once the clinical team have actually reviewed them and triaged them, they can then document what they're observing and what the facts are and make a clinical decision based on that. And psychological distress. What's going on for this person? Let's get the team in to see them now. All right. Category 5, attend the clinic soon. So again, it's unwell fevers, pain, particularly in those two categories of either in the spectrum, infant and elderly. Vomiting and diarrhea, same thing. They got a rash. Descriptions on the phone. It's a rash really hard, isn't it? What kind of rash is it? Like, I can't visually see that. So always nice to get them to come into the clinic so you can. And again, it's still severe flu-like symptoms, but I dare say that now that we've been through a pandemic, we've possibly changed the coming into the clinic, and that's more of that telehealth response instead. All right. So remember before I talked about the ISBAR framework, this is not it, but I just want you to consider why we might talk about it in greater detail in a moment, because we need to make sure that we're clinically handing over in a way that really gives the descriptions of what someone is presenting with. Now, I'm just going to read what Annika has written in the meeting chat. I think it's fantastic that it's really important that we stay cool, calm, and collected. It does not help if you're panicking when a patient is having a medical episode. Absolutely not. Okay. So, really important reminder that we communicate more non-verbally than what we do verbally. So your patients are going to pick it up if we're starting to panic and if we're starting to run around and if we're starting to feel like we're frantic. So again, remembering that calm composure, and how can you handle the situation can have a massive impact on effective triaging the event? Absolutely. So responding in that cool, collective way, getting your team members to come in and assist you, and keeping the composure there is absolutely useful. And that's why you do training such as this, as well as going and getting your basic life support or your advanced life support, depending where you work, up to date as well, so that you can feel like you can be in a bit of control. And don't forget to routinely run mock scenarios, because you're going to see very clearly who's actually running around feeling frantic and who's actually feeling nice and calm about the situation, because you've rehearsed this. You've got this as a team. Okay. All right. So do we like these handover statements? Let's have a look at this. I have someone on the phone with a stomach ache. Doesn't tell me much, does it? Or I have a 25-year-old, so you've got their age, who says again, we've got the observational language in there that she's had stomach pain for 3 days, diarrhea, and has been vomiting. We've got more information now. We can probably categorize according now versus just, I don't know where to put this person. Here's another one. I have a patient who burnt himself on the phone. Did he burn himself on the phone, like physically on the phone, or did he burn himself on a motorcycle exhaust, or did he accidentally was burning off? And he's, there's so many questions, isn't there, on that? I have an 18-year-old who's burned himself all over his leg, so both legs are affected, with boiling water 2 hours ago. Or you might have an 18-year-old who burned himself on his motorcycle exhaust pipe 2 weeks ago. Could be a variety, right? The more is more. Okay, so we might have infectious patients. It's important that we protect ourselves, as I said earlier on, making sure that we have got appropriate PPE, we've got isolation rooms, whether that's keeping people at home or keeping them in their car, and obviously protecting yourself as well as others and doing that deep cleaning if you do have someone who's exposed in your clinic, for the immunocompromised people and also your own staff's sake. Category 6. It's appointment within 24 hours, adult with a rash, but otherwise okay. Post-operative problems, eye and ear infections, and they got some pain. Now, I'm just going to say I was recently traveling and I had an ear infection, and I don't think I could have waited 24 hours. It was awful. I couldn't hear. I had severe headache, and I couldn't concentrate. So again, it's going to depend on what the symptoms are. Adults with continuous vomiting or diarrhea for greater than 24 hours. Other high-risk presentations might be someone who's immunocompromised, bleeding disorders, unstable chronic conditions, post-operative conditions, and patient expectation. So hopefully we're starting to kind of see, let's try and think proactively. The symptoms for eye and ear infection can jump between a category 6 and category 3. And this is where context is really important. Asking those extra questions will decide where you put them. And as I said, I'd rather you go up in terms of where you're prioritizing them rather than the 6, maybe to that 3 in the first instance. Getting your clinical team to do that. The medico-legal considerations, we need to make sure that we're documenting. As I said, we're very poor historians, knowing times, knowing doses, knowing what advice you might have given. That's super important. Making sure you're adhering to the policies and procedures and protocols of your site that you're working on. Having a consistency across the team. I have a family member, and it's not me, who is an ex-nurse, and now she works as a receptionist. And she said to me, I love working on reception. I can give people lots of advice. I'm like, you cannot give advice. You are not registered as a nurse anymore. And as tempting as it is, and you probably, do know the answers, you cannot, as non-clinical staff, give medical opinions or advice. And of course, there's vicarious liability. Let's have a look at a couple of those cases. Here's one from the courtroom. A GP has responsibility to ensure all patients seeking appointments are properly prioritised. The medical practice should have guidelines in place. The GP has a duty of care to properly instruct the medical receptionist on the proper management of patients who present with complaints which may require urgent attention. So when they say no, take a snapshot of this and say, absolutely, you need to help me, right? It's common ground that a well-trained receptionist would inquire about specific complaints, particularly the severity and duration of that complaint. That's why I say paper copy of that POPGUNS resource, and you can then fill it out, right? It's got those nudging questions on there so you won't forget to ask them, okay? Really important. So best practice involves policies and procedures that are clearly outlined that people can complete them in a consistent manner, having appropriate appointments, as I said, maybe to accommodate those urgent appointments, like the practice that I work for, who would point at a particular GP to be that on call. Have that POPGUNS resource or an alternate form that you are using and adapting, but all your staff are trained in, to do that non-clinical decision making. Giving some training of what a red flag might be. Now, someone made mention in the chat function before that not only do they use POPGUNS, but also their clinical team have said what else fits into those criteria. A team-based approach, you're not there alone. You're not there to make these decisions by yourself. So absolutely lean on your clinical staff to assist you. And absolutely, we need those effective communication skills. So just as a reminder, majority of it is that non-verbal. So you need to be seeing each other. And if you're not, we need to make sure that we're clearly communicating in a way that's useful for everyone, which is the ISBAR, which I'm going to talk through in a moment. But there's 3 critical things when you are communicating with another human that I want you to try your level best to do. One is to pay attention. Now, if you've got something going down which you need to triage, you need to be completely present, and you can't be picking up phones, you can't be chatting to other people. You need to be completely tuned into that person. And then I want you to repeat back sections of what that person's saying to you as you write it down and then circling on that POPGUNS chart. That means they can clarify if that's what they said. Sometimes we might not be able to catch exactly what someone just said. So again, you're repeating back. So you've got pain, you're saying it's 8 out of 10, you've had it for 2 weeks. And again, just those simple ways of just making sure that you're checking in, that you're understanding what that person's communicating to you, is super important. And then using open-ended questions so you get more narrative and more descriptions from them. So what can be a barrier? Absolutely the phone, right? You're only getting 2 components of your communication, which is your verbal words as well as maybe pitch and tonality. You're not getting the visual. You might have cultural and language barriers. You might feel pressured and you've got, staff off at lunch or whatever, and you're trying to do the best you can and answer a million phones. You could be distracted. There might be stuff going on in your clinic, and there may be a lack of understanding. Right, let's go and do a couple of case studies. If you came to last year's training, you might know and recall these. So let's see what you come up with. Have a look at your POPGUNS resource, the one that you downloaded from the chat function, or just open that up in the chat function. And I just want to see what your thoughts are. A parent rings. They've got a 6-year-old child. The child has a rash that suddenly appeared. There's no other symptoms. The caller requests to be seen immediately. What category are we putting this in? Just type that in the chat function and let's see what you all agree on. Right, Paul says category 6. Okay, category 5. I've got a category E. Some people must have different versions of the POPGUNS resource. A, B, C, D, E would be category 5, I guess.
I've just popped it back in the chat as well.
Thanks so much. Category E, so category 5. Category 6. Yeah, category 5. All right, so we want to go and err on the side of caution. Remember, I said always go up. If you're unsure, we'd rather be over cautious than under cautious. Fantastic. What about this one? Elderly patient rings. They believe they may have taken a double dose of their medication. What category do we think this is? 4, 3, 3, So I'm seeing A, B, C, D, E is the same as 1, 2, 3, right? C, yep, so 3. All right. Yeah, category 3. You all are winners so far. What about this one? A 72-year-old female patient presents in person and had chest pain in the pharmacy. Yep, category 1. Fantastic, fantastic, fantastic. And don't you love it? They were in the pharmacy, but the pharmacist sent them to you. Category 1. Yeah, great. Absolutely, category 1. What about this one? Unwell adult. So it's less clearly defined here, right? 35-year-old, generally tired. Oh, Paul says this happened to me. Happened to me too, Paul. 35-year-old, generally tired for past 4 days and would like an urgent appointment. What questions might you need more information about? What's your decision making here? Madison said, any other symptoms? Good to know a little bit more, wouldn't there? Did a change in behaviour? Yeah, would need more information to decide. Could be either way, couldn't it? It could really need more detail. And that's what I was saying before. You need more information here. Duration. We might need severity, right? We might need prior history, those sorts of things to really support us to understand what is it? Because it could be just basic malaise, like it could be like the lethargic, etc. So really important that we find out that further information. Now, as part of the pre-questions, it was a request that we actually talk through. If you're a nurse, what do you do in terms of triaging? So in response to that, thank you for whoever asked that. I just recently presented at a conference on this about nursing triage and handover. So luckily I had this up my sleeve. So what do you do if you are a clinician and you've got a responsibility? Now there's an Australasian triage scale, and I'll show you the resource when we go through the categories, and they are different from the POPGUNS resource. So the POPGUNS resources are for your non-clinical staff to navigate patients to where they need to go to. All right. And it's either hospital or get your GP or your nurse team involved. With regards to nursing, it goes through, and this is from accident emergency, right? And I'll show you where, as I said, I'll give you the resource link in a moment. But you'll see similar sorts of things, really, the cardiac arrest and respiratory arrest. But then it goes through with respiratory rates, blood pressures, GCSs, so more of your clinical parameters coming in through here. IV overdose, unresponsive, hypoventilation, severe behaviour disorder with immediate threat of dangerous violence. I think I'd be calling a few 000s for police and AMBOs there as well. Then we have category 2, where again, we've got some more clinical parameters around airway risk, respiratory distress, circulation issues, pain, and someone may mention before, and I dare say it was a clinician, the sepsis, physiologically unstable. Things can change very rapidly in that instance. They might be febrile. They might have low blood sugar levels, drowsy. They might have acid in their eye requiring irrigation. We can't do a lot of stuff in general practice. Sometimes it needs a little bit more high-level equipment and more staff members, more team. And then if we've got behavioural issues, psychiatric, violent, aggressive. We had one lady and she was a repeat offender, and she did this to us 3 times, and it wasn't a mock scenario. It was actually all hands on deck, and she was coming and seeing her psychologist. And then she locked that psychologist in the psychologist's room, right? And basically was having all sorts of episodes going on. But after we basically all hands on deck ran to help the psychologist, she barried the door. We got everyone there to help us get her, the psychologist out and her in a safe way, and finally got her out to, accident emergency with, with a lot of help, with a lot of medication and a lot of convincing. The second time around, she ran out of the building and ran onto the highway in front of cars. So, you know, there's lots of issues there, isn't it? So the more hands on deck you can get, the better. Category 3, and there you can see under the category, you'll see next to it the response time. Hopefully, oh, I can see a beautiful dog. Hello, doggy. Response time there is obviously start treatment within 30 minutes. So assessment and treatment all happen very quickly. And that's for severe hypertension, severe blood loss, persistent vomiting, head injury, limb altered sensation, child at risk of abuse, and again, behaviours, psychiatric turn up again. Assessment and treatment within 60 minutes. Hopefully this is giving the clinicians a bit of a guide on, you can print it out and, you know, put this on your clinician treatment room wall or wherever it is that you might be working. So again, we might have mild hemorrhages, aspirations, chest injuries, head injuries, moderate pain, eye inflammations, hot joints, abdominal pain. And again, there's semi-urgent mental health problems, but they're not under immediate risk to self-harm to themselves or others. Category 5, again, 120 minutes now. Minimal pain, low risk histories, minor wounds and abrasions, and again, social crisis, but clinically well patient normally. Now you can see under there that I've got the source link, and it's from the Australasian College for Emergency Medicine, and it's the guidelines on the implementation of Australasian triage scale in emergency departments. So I haven't made it up. It's a thing, but I thought that, you know, it just might give you some sort of consistency in an approach, particularly if you are a clinician thinking, you know, what sort of timeframes do I need to be abiding by? So this is a nice little guide, easy sort of reference that you can pop up there. And you can see it was just updated in January of this year, even better. All right, let's come back to ISBA. Now, someone wrote it very clearly in the chat before. I really love this resource. I think it's just a great little acronym just to remind you what are the critical components to share when you are handing over. So, you know, you might be in a treatment room and you're handing over to a GP. You might be off-site and you're handing over. You might work in a satellite clinic, for instance, and you need to hand over. So first and foremost, who are you? What's your role? And where you are and why you're communicating. Okay, so I'm Kim. I'm a practice nurse at satellite clinic, blah, blah, blah. And, you know, I've got a person here who I'm concerned about is talking about self-harm, for instance. What's happening at the moment? Put this person in to dress their wounds, and they've been describing, you know, ideation of self-harm. What's the background? What issues have led up to this situation? Has been describing to me lots of financial pressures, lots of stressors with family, and feels, you know, that not getting the psychology and the psychiatric treatment needed at this moment. What's the assessment? What do you believe? Okay, this is different, isn't it? When I said before, write down the facts. This is, what do you believe? This is you communicating across to another clinician. What do you believe the problem is? What's your instinct here, and what's your clinical assessment here? So this person is saying that they haven't been able to access, you know, their appointments. They can't get their medications. They haven't been able to afford them. I'm concerned about their well-being at the moment. I need someone to see them today. So the recommendation is I want someone to see them today, okay? No medications, hasn't been able to afford them, verbalising self-harm, there's ideation about that, and basically no one's been able to access care, all right? The really clear little framework to follow along so that somebody, when they are receiving that information, has a completeness of information. So there's less need for lots of questions back and forth, back and forth, back and forth. And it also reduces the likelihood of missed data really critical that we provide comprehensive information so someone who may be remote to us in terms of workforce and staff can make an accurate clinical decision. And it's easy in a focused way to set expectations on why I'm concerned. Like, say, for instance, when I said before that sometimes I'm getting bounced from doctor to doctor to doctor, in the end, I'd just say, I have been, spoken to 6 people. They've all said they're too busy. You need to help me. Okay. So ensure recommendation is clear and professional, gives confidence in that communication, particularly if you're doing that in front of a person. If you're calling and you've got the person next to you, either in a treatment chair or a room, and focuses not on the people who you are communicating, but on the problem itself, which is important. ISBAR's portable. You can use it anywhere. It's memorable. You can use it to present information really clearly in any situation, and it helps you organise and gather your thoughts in a way that's clear and calm, which we said before is really important. People see someone rushing, they see someone panicking, and they start to escalate. And it standardizes that communication across your team and those pathways. Now, let me come back to all of you. Hello there, everybody. I hope you have got lots out of tonight's session. I've got here 9 minutes to answer any questions that you might have. But in the meantime, while we're waiting for some questions, I'd love for you to just write down what's a key takeaway for you tonight. It might be ISBAR, it might be the POPGUNS resource, it may be about those nursing clinical guidelines and timeliness. Could be anything. It could be just that you've had a refresher with your team tonight and you've had an opportunity to talk through what your policies and procedures are and how you go about it. Might be that you got a hug from a dog halfway through. I saw that. All right, so let's see a couple of those key takeaways there. We had a similar situation where a female patient with a mental illness and history threw a brick through our front windows because the doctor wouldn't prescribe opiates. Yeah, this is the stuff we're dealing with, right? Lots of there's this dog back again. Yeah, it's a hard situation to be in, isn't it? And that's where we need people like the police, maybe our security, etc., to help us. And more hands on deck is always a good thing, but there is always going to be drug-seeking behaviour, and people's behaviours are not necessarily always going to be to our pleasing. Yes, you can get a copy of this as well. Ask more questions about symptoms, need more information, definitely to triage. Yep, could we place that? Yep, you can have a look at the recording. No worries about the ISBAR. It's great essential framework there. The categories are great. Yes, absolutely they are. And know when to wait. And good refresher, I did this last year. Thank you, Simone. Nurse triage guidelines, putting it in perspective that we can ask questions and not feel like we're being intrusive. Absolutely not. Yeah, great. I learned POPGUNS more in depth. I'm new to the medical industry. Welcome to the medical industry. We love it. And thank you for coming and joining our tribe. And we really, really hope that you absolutely share this recording and share these resources and your knowledge further. Yeah, it's great, isn't it? Thank you for pleasure's mine, everybody. So feel free, there's an evaluation link that Kayla's just popped in there. It's really important that we get that feedback, good and bad and the ugly, so that we can always make sure that we're providing education to you that's interesting, of use to you. And of course, I'm really grateful the people that put those questions in at the start that wanted more information for the clinicians as well. So, I've always got those sorts of things there. And more than happy to provide those sort of extra links and so forth as well. Great. Thanks so much, everybody. So lovely to see a lot of faces there. Great. Pleasure, and pleasure. So will you be sharing the group chat or emailing the nurse triage? I can certainly email them to Kayla.
Yeah. I'll send an email out to everybody in the morning with all of the resources.
Yeah, great. And it's, I don't want you sitting there trying to, write notes at this time of night. Absolutely happy for you to share them, because then you potentially will share them more broadly with your team as well. And hopefully you'll go to the other skills face-to-face. Have you got the dates for those nights
For the
or
essential.
days? They're Saturdays, aren't they?
Yeah. So Saturday, 24th of August in Mackay, Saturday, 31st of August in Townsville, and then Saturday, the 7th of September in Cairns. So I can send out those flyers as well, just so you've got them handy.
Excellent. And did I not say that I would be on time, hey? All right. Well done, everybody.
Thank you so
Thank
much,
you so
Kim.
much. Pleasure's mine.